Xiros Limited are proud to present the FlexPasser, a revolutionary approach to tendon retrieval. It is an exciting innovation in flexor tendon repair. The FlexPasser is a single-use device for atraumatic retrieval of lacerated tendon stumps quickly and consistently. The aims are to minimize tissue dissection, tendon handling, tendon trauma, and trauma to the delicate tendon sheath. The FlexPasser was developed in the UK in collaboration with and for evaluation by Miss Anna Barnard, consultant hand and plastic surgeon, and Mr. Alex Jones, consultant plastic surgeon. FlexPasser usability testing took place in 10 cadaveric laboratories using fresh frozen specimens mainly in the UK. These were led by Mr. Jones and Miss Barnard, with some labs taking place in the USA. More than 10 senior consultant surgeons evaluated the product. Each surgeon used the FlexPasser to retrieve divided flexor tendons in zones 1 and 2 in 2 or 3 fingers. Some FPL retrievals were completed in the thumb. This was also felt to be easier than standard techniques, provided care was taken with MCP joint positioning. This is how the device looks in practice. A flexible probe to pass atraumatically through the tendon sheath while introducing a thin soft liner into the sheath. The tail of the probe is more flexible than the tip. This flexible tail allows it to act as a carrier to transport a curved needle without damaging the tip, as will be shown later. A loop of strong wire is firmly attached to the probe and emerges from the flexible needle carrier end in order to pull the sheath liner through the tendon sheath. The dual sheath liner is folded over the wire loop. The needle carrier can accommodate a range of curved needle sizes up to 26 mm. At that size, the needle must not have an arc more than 3/8. This is more than sufficient for typical flexor tendon repair materials such as round-bodied Prolene and Ethibond. The flexible needle carrier accommodates both the free end and the curved needle of the core suture used for the tendon repair. After the first part of the core suture repair has commenced, the needle and free end are now completely within the flexible tail of the probe, as is shown here. Advance the probe through the opening in the tendon sheath from the site of the laceration to the site of the proximal tendon. Hold the probe near the opening of the tendon sheath to avoid buckling of the probe. Pull the probe through the proximal incision. The plastic sleeve should protrude from both incisions once in place. Cut across the full thickness of one leg of the sleeve obliquely. The leg that has not been cut is then removed from the digit, leaving a single sleeve in place. The proximally retracted flexor tendon stump is sutured. The needle is to be kept on the suture. The free end of the suture is introduced into the open end of the needle carrier to about 4 to 5 centimeters. Then the entire body of the curved needle is introduced into the carrier section, gently curving the carrier section to preserve the needle tip. The probe is threaded through the plastic sleeve from the proximal to distal incisions and removed at the distal incision. The needle and suture are released from the needle carrier. With gentle traction applied to both ends of the suture, introduce the proximal tendon stump into the sleeve, guiding it through the cavity and to the distal wound. The sleeve is then removed from the distal wound. The two stumps can now be connected with the same needle and suture material. The retrieval of a single tendon is demonstrated on a cadaveric hand. Introduce the FlexPasser into the entrance of the lacerated tendon sheath, pushing it incrementally near the sheath entrance until it emerges at the palm. Draw the FlexPasser further until the liner protrudes by approximately 5 centimeters. Cut the upper leg of the liner, then remove the uncut section. Suture the tendon stump as preferred by the surgeon. Introduce the FlexPasser probe into the liner until it emerges at the distal end, where it is clearly visible through the liner. Introduce 5 cm of the free end of the suture into the hollow of the curved needle carrier. The full body of the curved needle is introduced into the hollow of the carrier, which is pushed through the liner. The tendon stump is introduced into the liner and the FlexPasser is pulled out of the liner at the distal end with the curved needle in its carrier. And the tendon stump until the latter emerges at the distal end. Thereafter, the liner is removed. Lacerations may occur to 2 tendons in the same digit, for instance to the FDP and FDS. Since both require retrieval and repair, both should be delivered to the palm. Should then be placed in the anatomic orientation prior to proceeding, as was just demonstrated in the procedure for retrieving a single tendon. Each tendon stump should be sutured independently. And 1 suture pair at a time should be passed through the plastic sleeve. Then all 4 suture strands are used to draw the 2 tendons simultaneously to the distal incision. The repair connecting these tendon stumps to their respective stumps is then completed with the same sutures and needles that were used to retrieve the tendons. Our first clinical case is that of a 17-year-old male who had a typical closed FDP avulsion following a rugby match affecting his dominant ring finger. He had a primary repair day 3 post-injury by Mr. Chris Copes, the consultant hand surgeon. He noted that the FlexPasser enabled smaller access incisions than are sometimes required, both of the palm and at the distal interpharyngeal joint. He noted that the tendon retrieval was faster and more efficient than standard techniques such as the feeding tube or whip stitch. He found that once the tendon was retrieved using the core suture of the planned repair, the tendon damage was reduced and time was saved. Unexpectedly, the same case returned a few days later, having had the button-over nail tendon repair cut off by the school nurse at day 10. At day 12, Miss Sarah Kettle, another consultant hand surgeon in Middlesbrough, used the FlexPasser once again to repeat the primary procedure. She found that there were minimal challenges and did not require any additional wound extensions. She was also surprised with the quality of the tendon end post-retrieval. Thankfully, the patient went on to make a good recovery. The FlexPasser facilitates a minimally invasive surgical procedure, which should save dissection and suturing time in theatre and enhance recovery. Tendon retrieval is faster and easier with less snagging, for example at pulleys or Camper's chiasm. The core suture can be commenced prior to retrieval and used to retrieve the tendon, minimising tissue handling, trauma to the tendon end and saving time and materials by avoiding a separate whip stitch. The curved needle of the core suture can be passed through the entire flexor sheath without blunting or injuring the sheath, as the cutting tip is protected within the flexible probe tail. Savings should exceed the cost of the FlexPasser. By reducing operating theatre time, fewer suture materials and feeding tubes required, reduced tendon handling and trauma from repeated suturing should improve tendon healing and reduce rupture rates. Reduced tendon sheath damage should reduce adhesions. Shorter surgical incisions should reduce edema, scarring, and pain to enhance rehabilitation. Fewer secondary surgical procedures and hand therapy costs due to the above. We conducted early blind research into what hand surgeons believe were the key factors that impact their outcomes for flexor tendon repairs. These two statements seem to resonate with the wider group. The same group of hand surgeons then had the opportunity to review the FlexPasser. Their early comments are reflected by these statements.